Imagine your chest suddenly feels uncomfortable. Your heartbeat is fast, uneven, chaotic. For millions of people, that feeling is atrial fibrillation, also called AFib. Some people may not notice it at all, while others can feel almost anything: exhaustion, dizziness, shortness of breath, chest pain, lightheadedness, nausea. Truly, almost any symptom is possible. Today, I want to explain what atrial fibrillation actually is, what causes it, when it can be dangerous, what happens in the emergency department, and what treatments exist, all in plain English so that we can all understand it together. My name is Venk Bellamkonda, emergency physician at Mayo Clinic, father and husband, and a patient. I've had open heart surgery as well, and my mission is to help people understand their healthcare issues better so they can make better decisions on how to live. As often is the case, stick around to the end of the video for a free downloadable worksheet to help make any visits to the ER with atrial fibrillation easier for you. Let's start with what AFib actually is. Your heart has two chambers on the top and two chambers on the bottom. When things are working normally, the top beats just a moment before the bottom. If they were dancing together, the top is the leader and the bottom of the heart follows. The two work smoothly together normally. In atrial fibrillation, the top doesn't actually squeeze, but rather it shakes. Not only that, it shakes without a regular pattern, and oftentimes it shakes too fast and sometimes too slow. The bottom of the heart sees this irregular and chaotic shaking and tries to keep pace. This leads to the irregular pulse that people may feel or recognize as their atrial fibrillation. The actual rate can be normal and irregular, fast and irregular, or least commonly, slow and irregular. The bottom of the heart is the part that actually pushes the blood throughout the body. So when it is irregular and when the number of beats is not correct, that is why people with AFib often describe sensations like fluttering or pounding, racing, skipping beats, or chaotic heartbeats. Or if it's too slow, they can describe feeling lightheaded, tired, weak, dizzy, or even passing out. Some feel short of breath when walking upstairs, some feel chest discomfort, and some people feel almost nothing at all and only discover they have AFib during a routine exam or by some other unexpected way. So where's the problem? AFib is an electrical problem, a timing problem. That leads to one of the most common questions people ask. Is AFib the same thing as a heart attack? And the answer is no. Is AFib caused by heart attack? It's really pretty rare. It's not a plumbing problem. It's an electrical problem. With that said, many very talented and caring health professionals can confuse the situation. If someone checks a blood test called troponin, when a patient has a really fast heartbeat from atrial fibrillation, it can show an injury to the heart is happening. This is a type of heart attack. The best thing to do is to manage the AFib. So it's not that the heart attack is causing AFib, but rather the AFib is causing a type of heart attack. The ugly truth is that most commonly, we never find a specific cause for a person's atrial fibrillation. AFib becomes more common as people get older, yes, but age alone is not the only risk. There are also many other things that can contribute to it. High blood pressure, sleep apnea, obesity, diabetes, heart valve problems, lung diseases like asthma, COPD, or blood clots in the lungs, thyroid issues, all of these are potential causes. In addition, certain electrolyte problems, drinking alcohol or caffeine in excess, using stimulant medications, recent surgery, infections, dehydration are also on the list of things that can cause AFib. There is even something informally called holiday heart, where people develop AFib after drinking large amounts of alcohol during vacations or celebrations like Christmas. And importantly, remember, sometimes AFib happens in people who are seemingly healthy and are living healthy lifestyles. Just having an irregular heartbeat is not necessarily dangerous, however. As we mentioned, the top of the heart doesn't actually squeeze, and the blood doesn't move properly in that section. When this happens, sometimes blood clots can form there. Then, if sometime in the future the heart starts to beat normally again, well, that clot can get pushed out. And if it goes to the brain, it can cause a stroke. Similarly, if it goes to the intestines or somewhere else, it can cause major problems there as well. To prevent this from happening, some people with atrial fibrillation are safer if they take a medication that makes blood clots less likely. This can keep them from having a stroke. One of the more common medications is called apixaban, or the brand name Eliquis. These medications are called blood thinners as a category. These clots don't form within minutes of going into atrial fibrillation, though. They take time to happen. Typically, we're talking about being in atrial fibrillation around 48 hours when clots begin to form. So if someone is already on a blood thinner like apixaban, and they go into atrial fibrillation, but they generally feel okay, well, there is not as much need to go to the emergency department in that circumstance. Certainly, if they feel bad, having chest pain, shortness of breath, dizziness, confusion, or feel like they may pass out, well, that's different. They should come to the emergency department immediately. But if someone is on one of these advanced blood thinners and feels pretty good in atrial fibrillation, well, then they could potentially check in with their family doctor or heart doctor. But if you're unsure at all, come to the emergency department without hesitation. Usually one of the first things done is to check the electrical workings of your heart. This is with an electrocardiogram, also called an ECG or EKG. Also, very quickly, the team will check your blood pressure, oxygen levels, heart rate, and talk through your symptoms. Blood tests are often performed, and probably a chest x-ray is ordered to see the structure of your heart. In some cases, an ultrasound or CAT scan may be done as well. One of the important questions your healthcare team will try to drill down on is, when did the atrial fibrillation start? And how confident are we about this start time? We also ask whether someone has had AFib before, whether they take blood thinners, and more details about the major new symptoms, the chest pain, breathing troubles, lightheadedness that I mentioned before. In general, for atrial fibrillation in the emergency department, we have to figure out if we should force your heart into a normal rhythm, or if we should manage the heart rate and allow your heart to remain in atrial fibrillation for the time being. If we know very certainly the time you went into atrial fibrillation, and especially if you're on a strong blood thinner medication like apixaban, then forcing your heart into a normal rhythm may be the best way forward. This can be through medications like amiodarone, propafenone, flecainide, and several others. Or believe it or not, we may talk to you about making you asleep for a few minutes and using an electrical shock to push your heart into a normal electrical rhythm. I know that may sound very scary. In shows like ER, etc., this involves a lot of drama, and there are paddles being maneuvered to do the job. In real life, sometimes there can be urgency if a person is very sick, like bad blood pressure or not waking up kind of sick. But if your doctor has a chance to sit down and talk to you about this option, most likely they're not planning a chaotic procedure. There will be a more calm, controlled version with a planned out experience. We give the patient medications to go to sleep. Also, instead of paddles, we have large stickers that we put on the chest now, and they work fantastically. If we're not going to force your heart to beat normally, but rather manage the heart rate, as I mentioned, so it's not too high or too low, then we have several medications that we can use, including things like diltiazem or metoprolol. There is a tool that helps us predict how at risk someone is of developing those blood clots that we spoke about earlier. This is called the CHADS-2 VASC score. This score is backed by many research articles and by large scientific groups like the American Heart Association, the American College of Cardiology, the American College of Chest Physicians, and many more. This tool uses a person's age, sex, whether they have high blood pressure, diabetes, history of stroke or mini stroke, history of blood clots, whether they have certain blood vessel or heart diseases, and do they have a history of congestive heart failure, to predict the risk of atrial fibrillation causing a stroke. The tool is far from perfect, though it's pretty good and certainly the best current evidence we have for deciding if someone should be on advanced blood thinners or not. Being on medications like apixaban can really keep people safe from stroke in many cases, but they also carry the risk of bleeding. So the decision is an important one with significant stakes. You may hear different descriptions of atrial fibrillation or different types of atrial fibrillation: slow AFib, persistent AFib, paroxysmal AFib, and more. Let's go through some of those terms right now. Paroxysmal atrial fibrillation is when someone has episodes of atrial fibrillation but are not in that rhythm most of the time. Persistent atrial fibrillation is when someone is in atrial fibrillation so much, this is usually applied if the patient is in atrial fibrillation for more than 7 days. Long-standing persistent atrial fibrillation describes when atrial fibrillation has been continuous for more than a year, but there's still some degree of hope, or at least effort being put forth, to return the rhythm to normal if possible. Permanent atrial fibrillation describes atrial fibrillation that is both continuous for more than a year, but also that the patient and doctor have decided not to try to get the rhythm back to normal any further. Situational or triggered atrial fibrillation is a description sometimes given when AFib occurs in a certain situation, like surrounding a surgery or near the time a new diet has been instituted. Idiopathic atrial fibrillation describes AFib that happens without a known cause. Slow AFib describes when someone is in atrial fibrillation but has slower than normal heart rate, usually under 60 beats per minute. Fast atrial fibrillation, by contrast, describes when someone is in atrial fibrillation but has a higher than normal rate, usually over 110 beats per minute. Another term for this is being in rapid ventricular response, or RVR. Finally, let's talk about long-term outlook and living with AFib. The good news is that many people live long, full, active lives with AFib. There are many effective treatments available today, and lifestyle improvements can make a huge difference. Treating sleep apnea, reducing alcohol and caffeine use, exercising regularly, improving blood pressure control, managing diabetes, maintaining a healthy weight, getting good sleep can all help reduce AFib episodes and improve overall heart health. Atrial fibrillation can cause a variety of symptoms, from pains to weaknesses, but it can also have no symptoms at all. The main risk is that it can cause strokes if not treated. The most important protection from stroke is to use a blood thinner medication, but only for the people who are at most risk. We determine that risk using the CHADS-2 VASC score. If someone has atrial fibrillation but does not feel too bad, and especially if they are on blood thinner medications, they may be okay connecting with their family doctor or cardiologist. If someone feels unwell, like having new chest pain, lightheadedness, dizziness, shortness of breath, just come to the ER to get seen. In the ER, you can expect to have the team talk through your symptoms, examine you, review your medications and history, check some blood tests, get an electrical survey of your heart called an EKG or ECG, often get pictures of your chest with an X-ray, ultrasound, or possibly a CAT scan, and then you can expect to have a discussion about medications to control your heart rate, or methods to push your heart into a normal rhythm, including using controlled electrical shock. You are truly one of my favorite people for staying with me to the end of this video. I know it's been a long journey. I'm going to share a QR code for a downloadable worksheet to help make any future trips to the ER easier for you. Remember, smart health fuels smarter living.